I'd like to introduce Dean Thomas Cavalieri to start our program.
Well, good evening, everyone, and welcome to the RowanSOM Alumni Association's monthly webinar series. I'm Tom Cavalieri, the Dean of Rowan University School of Osteopathic Medicine. I'm very grateful to our wonderful alumni, our alumni board, for their efforts in putting this together, working with our Office of Alumni Engagement and our Office of Fundraising, so to speak, with Gail Foreman, our Director of Advancement. This evening, we're pleased to bring together another installment or episode of our alumni webinar series that is becoming increasingly popular. This program today is called When to Go to the ER and What to Expect in the Time of COVID-19. We're looking forward to an informative conversation and information sharing from our experts about the preparations that our hospitals and emergency rooms are taking to make patient visits safe. This panel will also explore health outcomes for patients that delay care due to the pandemic and share their advice about when you and your loved ones should go to the emergency room. The format of this webinar will include a moderated question and answer, followed by a Q&A from our attendees, all within approximately 1 hour. As a reminder, you may submit your questions at any time in the chat, so they can be shared with the panelists during the session. It's now my pleasure to introduce our presenters and participants. Dr. Vic Scali, a distinguished fellow of the American College of Osteopathic Emergency Physicians, is currently retired from clinical emergency medicine, but I'll tell you, he's far from retired. He's actually serves as a facilitator and director of the problem-based learning curriculum for first and second year students here at RowanSOM, and we are delighted to have him as a very valued, distinguished faculty member here. Vic has received numerous honors and recognitions in the field of emergency medicine during his esteemed career. Two recent honors for Dr. Scali just recently this month included the induction into the Gold Humanism Honor Society. That was just the other night. What an honor. He also received the New Jersey Health Foundation's Excellence in Teaching Award just recently. Vic will serve as the moderator of the program, and Vic, we're so grateful for all you do in so many ways for our school, our students, our alumni.
Thank you very much, Tom.
I am pleased to introduce Dr. Michael Bruzak, a 2010 graduate of SOM. He serves as the Director of Emergency Medicine at Capitol Health, Deborah Heart and Lung in Browns Mills. He completed his emergency medicine residency training at Morristown Medical Center. As a student leader, Dr. Ruzek created the Community Grand Rounds Lecture Series, a collaboration of SNMA and our Dean's Office. He is on the NJOPS board. He has two beautiful children, and I'll take a little credit. I mentored him a lot during his stay here. I have to take credit for you, Michael. I'm so proud of you. And of course, we're proud of Dr. Tracé Dotson, a 1999 graduate of our school. She's an EM physician at the Advent Health Celebration in Celebration, Florida. She's employed with the Florida Emergency Physicians of Team Health. She has 17 years of emergency medicine experience. Dr. Dotson also operates a global skincare business and serves as a member of the Diversity and Inclusion Council of Rhoda and Fields. Tracy, thank you for being with us. It's great to see you, have you with us. We're proud, very proud of you. Also with us is Megan Martinson, who has more than 10 years of experience in emergency department nursing. She's certified in emergency nursing and pediatric emergency nursing and has worked in EDs, large and small, trauma centers, burn centers, community hospitals. Nurse Martinson is the nurse manager of the Capital Health ED at Deborah Heart and Lung in Browns Mills, and we are very happy to have her join us. I am also pleased to introduce student Dr. Melvin Ways. He's a member of the class of 2023. He will assist us with today's program. Melvin, I know you do much for our school, and I'm proud of you too. Finally, I welcome and thank our SOM team for hosting this program. Mr. Dean Michichi, our Assistant Dean for Student Programs and Alumni Engagement. Gail Foreman, the Senior Director for Development here at the Stratford campus. And Ms. Brittany Quintana, Program Coordinator for Student Affairs and Alumni Engagement. Vic, Michael, Tracé, Megan, thank you for your participation in tonight's program and your support of RowanSOM and our Alumni Association. I'll now ask Dr. Scali to begin the program. Vic?
Good evening, everyone, and welcome to the Rowan Alumni Association's webinar series. Our topic tonight, as Dean Cavalieri said, is when to go to the emergency department and what to expect in this time of COVID-19. I'm Dr. Vic Scali, your moderator for tonight's program. You've met our distinguished panel who will lead tonight's discussions. And as Dr. Cavalieri said, if you have any questions along the way, please print them into the chat or comment later at the end of the webinar. So let's get started. I think we're going to move right to our second question of the night for Dr. Tracé Dotson. And there seems to be some public confusion when a patient suspects that they might have COVID-19 infection, determining whether they should be seen in the ED or see a primary care physician. Can you discuss some guidelines for patients when it is recommended to be seen in the ED?
Absolutely. Great evening, everyone. And forgive me for not having mentioned I'm a mom of 4. My children would kill me. After 17 years of ER, I need all the prayers. So, you know, I love that we are a connection in the emergency room to healthcare. And I love that as osteopaths, our principal function of preventative care and of making sure the whole person is cared for, we get to do that and have our community connections with our primary care physicians. So when we talk about the necessity of when it's a primary care issue versus an ER issue, sometimes we know the lines are blurred. Very honestly. But we love that we are able to share with our patients and presently with our community and all who are here that your basic medical care, your basic medical needs, your hypertension, your diabetes, your diabetic foot ulcers, you know, all the things that, you know, high cholesterol, things that, you know, our mainstays of health, absolutely should be monitored. And, you know, a lot of us, you know, obviously had some concerns about showing up to the ER or showing up to the primary doctor in the midst of this pandemic. However, it is safe. It is okay. We're going to go further into that with all of us, but it is okay. You know, we've all pledged an oath to care for you, and we would not risk you by allowing you to come into our offices or the ER unsafely. But for primary versus the ER, for anything that is not a critical emergency, or, you know, things, for example, sudden pain, things that are going to, you know, have manifestations of, you know, chest discomfort or stroke symptomatology, which we'll go through all the things further, you can see and contact, right? Because a lot of us are doing telehealth or phone calls. Absolutely reach out to your primary doctor for basic skincare, for basic healthcare concerns. My blood pressure lately is rising higher. contact the primary doctor. I'm having a low-grade fever, but I'm not having any overt difficulty in breathing. You can contact the primary doctor. I've run out of my prescriptions. That is not a requirement to come into the ER, although we will honestly help you, of course, but you can contact the primary doctor. So the mainstays and primary things that you've always gone to the primary for, your history and physicals, wellness exams, I need my lab work, I haven't had it done in 6 months, the primary can see you for that, but you can always reach out to them and they can guide you also when to come. Things obviously of urgent nature, bone fractures, heart symptoms, slurred speech, alterations, things that are life-threatening, we absolutely need to see you in the ER.
Excuse me. One further question, Dr. Dotson. What patients that suspect that they might have a COVID infection should call 911 for transport to the ED instead of by personal vehicle?
Sure. So things that have, and I don't pretend, right, to make families nor patients have to discern for themselves, am I a 911 candidate, right? But I will, we can all gauge if you're laboring, if there's a definitive struggle, if, my typical getting up to go to the restroom is exhausting me. I cannot catch my air. So things where you have these sudden, urgent alterations of who you are. I have heavy chest pain. We have, percentages of cardiac patients who have not come to the ER for fear. We need you there. We can do our best service for you there. So chest pain patients, sudden onset discomfort, trauma victims, unrelenting shortness of breath that does not calm or does not ease, we need to see you.
Thank you, Dr. Dotson. Oh, I see Megan has joined us. I have a question for her. Welcome, Megan. During the current phase of the pandemic, about 10% of the patients that we are seeing in the EDs here in the area of Stratford and Gloucester and Camden County are about 10% positive. What is your emergency department's protocol for walk-in patients in triage to maintain their safety as well as the staff safety during the COVID-19 pandemic?
Hi, yeah, can you hear me? I have been having some technical difficulties, but I'm working as best as I can as everybody has.
Well, Meg.
Very good. So yeah, we have a lot of processes in place to make sure that any patient coming into the department is screened on entry. So for a long time, we didn't have any visitors coming in, so patients were just getting dropped off. Right now, we're screening both patients and visitors before they walk into the department so that we make sure that we're putting them in an appropriate room, so that we have a negative pressure room, rooms with doors. We're asking the questions, have you had any exposures? Do you have any symptoms? And we're temperature screening everybody as they come in the door. And that includes all of our local police and first aid as well. They're being screened. And the people who are coming in from outside agencies, if we have peer counselors, social workers, prison guards, anything you can think of, we're screening everyone to try to prevent anybody from a inadvertent exposure in the department.
Are you using rapid COVID testing? Megan, can you hear me?
Oh, yes, now I can hear you.
Oh, good. Just wanted to ask, are you doing rapid COVID testings with quick turnarounds?
Yeah, we actually have a point of care testing in the department that gives us a result in about 30 minutes.
That's great.
Yeah, it's amazing. They say it's about 85% accuracy, so we obviously still make a clinical decision as well when we're determining where the patient should go after the fact of their ED visit, whether they're being admitted or transferred to another facility. We make sure that, we're following all the protocols if the patient is a suspected COVID patient, even if their point of care test comes back negative.
Great. Thank you very much.
You're welcome.
Dr. Ruzek, I have a question for you. Many physicians have observed in the COVID-19 patients that were described as either having silent or occult hypoxemia. And these patients apparently can look clinically not short of breath at rest and still have oxygen saturations in the 80s. Have you seen this phenomenon? Is it rare, or how are you treating it when you see it?
Well, thank you for the question, Dr. Scali. And before I answer the question, I just want to say how happy I am to be with the fellow distinguished guests, colleagues, and everybody that's viewing us tonight. So thank you for joining us. So I did bring props. So, you know, functioning hypoxemia is something that we do commonly see in the emergency department in the age of COVID. We see it to the extent that we haven't seen patients functioning at such severe hypoxemia as we do in COVID. I have seen patients walking, talking, and functioning with a pulse oxygenation as low as 50%, sometimes even less. And I'm thinking to myself, how is this patient even speaking to me with such a low oxygenation? You know, for those who aren't in the medical field that are on the call, we would usually expect an oxygenation of 97% or higher. So to see an oxygen level, a pulse ox of 50% or less on a patient who is talking to us is really something that we have taken notice. One thing I can recommend to patients, if the question of hypoxemia comes up and they feel short of breath, is a small, inexpensive tool, a pulse ox. So you could order this online. You could buy this at your local pharmacy. I paid $30 for this one, and it functions pretty accurately. And just like you could check your blood pressure at home, you could simply put this on your finger, and it'll give you your oxygen percentage, your pulse ox. So this is something that I recommend that, you know, everyone in the household should keep at least one in the cabinet and really reach for it when the question of oxygenation comes up. So that's something you could simply do. But again, you know, we've been taught, and one of my teachers is Dr. Scali, was treat the patient, not the number. So that's something, you know, that we take in mind and we practice. So you as a patient, if you don't feel well, no one knows themselves better than you. If you don't feel well, I recommend in this day and age, do not delay your care. Come in, be treated, and best case scenario, you'll go home with peace of mind, knowing that you're doing well. And if you need to be admitted and treated at the hospital, then you know you definitely did the right thing. But either way, you know, with the steps that we have taken to make sure that you're treated in a safe environment in the ED, Megan touched upon those steps earlier. I think you're better off coming in and being treated if your health is ever in question, and we're there to care for you in a safe setting in any ED throughout the country.
Thank you, Mike, for that information. That was very valuable. I want to move back to Megan again for another question related to patients walking in. The commercial news has talked a lot about the lack of adequate personal protective equipment for doctors, nurses, and technicians in the ED. Do you have the proper supply of personal protective equipment now to feel comfortable treating these COVID-19 infected patients?
Yeah, emergency nurses tend to be very creative and very resilient. And we also have a really good connection. You know, we always say the emergency department is a small world, but through this pandemic, what we've found is it really is even smaller. We've used the ENA connection to make sure that people are sharing information. And I'll be honest, the hospital I was working at when this the first wave hit, we had a nice connection with some docs who worked in New York City, and we were able to share that information and kind of get that to our hospital leadership kind of before it hit us here in New Jersey. So at the time, when the first wave really hit, we did have some challenges with PPE. We found ways to sanitize N95 masks, which was something that we had never considered before. We really pushed our PPE to the limits. As the wave has kind of changed over time, we've had the opportunity to stockpile, stock up, knowing that this second wave is really upon us, as the governor said today in New Jersey. We've had the ability to plan ahead and prepare and make sure that we have everything. But we did get very creative for a while. Capitol Health used a parachute company to make gowns for a while.
Wow.
And had laundry on site, which was really neat. So it was amazing how much the community came together and worked together. But right now, yes, we're in a good place. We have a good supply, and it's definitely one of those things that we're making sure that our team is using to prevent any cross-contamination between patients. We wear the PPE to protect ourselves and our families. But we also have processes in place in the department where nurses and techs are caring only for the potential patients. They have kind of their own zone, so they have limited risk of contaminating anybody else in the department.
Thank you, Megan. The next question I have is for Dr. Dotson. It's been observed that COVID-19 patients frequently have complained about loss of sense of smell and taste. Is this a phenomenon that you're seeing frequently? And what are the most common presenting symptoms in COVID-19 patients?
Hey there. So yes, in my experience, and I actually have made it a part of my questioning, right? All of us have become more creative in terms of what we need to directly ask. I'm finding about 50% in my experience of my patients with the loss of smell or taste. And then statistically in literature, it's only about 10% surprising with rhinorrhea, runny nose, some abdominal pain, as well as the smell and taste. But our overall top symptoms for presentation with COVID-19, about 50% are cough. And so I'm always surprised when my patients who are positive tell me I'm not coughing. I'm like, what do you mean you're not coughing? But you're supposed to, okay, fine. So I'm learning. We're 17 years later, we're also learning, right? The second most common presenting complaint is fever. And by fever, everyone in the community, so 98.6 is our textbook standard. 100.4 is what we in the medical world consider a fever, but I will tell you, yes, 100.2 does not feel so good either. So we understand, but just to share that with you. And the third most common is actually muscle aches, myalgias, which, as you can imagine, with flu coming, it's tough to discern. So we all, are going to be kind of plugged in. Then you have shortness of breath at about 29%, headache, 34%, sore throat at 20%, diarrhea, even though we mentioned that abdominal pain itself, only 10%, but diarrhea is higher, with nausea and vomiting being 12 to 19% or so.
Very interesting. My next question is for Dr. Ruzek. It's been widely reported that we still don't have enough rapid tests available to flatten the curve of the COVID-19 infection rate, particularly with this second wave. Do you believe we can test our way out of the pandemic with contact tracing?
Thank you for that question, and that's a very good question. And that's a question that comes up often. The availability of tests have varied based on the demand for testing. Certain states maybe have more availability than others from what I understand. For example, I have colleagues of mine that practice in Texas, and for them, for some reason, tests are a lot more available than they are in New Jersey. So there's logistic issues there when it comes to testing, and we're working our way through that. So when testing is limited, we have to be judicious. For example, in most emergency departments, routine testing is not conducted because the testing is really reserved for patients who are clinical and need clinical interventions. So if the patient is presenting with viral symptoms, has normal vitals, normal workup, and otherwise is a functioning individual with no comorbidities, there is not really a reason to rapidly test them right then and there, because it really won't make a difference, because really the intervention will be continue to self-isolate, and practice good hygiene and make sure you prevent exposure to others. So thank you for that question. I think testing, whether it's readily available or not, is only part of the solution. I think just being smart and taking proper precautions, I think, is the most significant component of the solution. And I'm really proud that, a lot of individuals around us, the message is resonating. People are wearing their masks, washing their hands. They're conscious of not spreading the virus. And I think that's going to be key. I think we're going to see vaccines and treatments, and it's going to be a multi-pronged approach. But, as long as we're in it together, I think we'll all get through this.
Thank you, Michael. Moving back to Megan, I have another question on the overall milieu of the ED. First of all, I wanted to know, how many cloth masks can you make out of one parachute?
Yeah, I'm sure you could probably make quite a few. They did pretty good with the gowns, so.
Well, I have a better question for you. It's pretty intuitive that ED personnel are exposed to many COVID-19 positive patients per day and bring that fear home with them every day. When your personnel are coming to a new shift in the ED, is there any self-screening protocols or any testing done to assure that your staff is safe?
Yeah, that's actually a really good question, and it's different depending on where you work. So right now in the facility that Dr. Ruzek and I work in, we do self-monitoring. So everybody is just asked to self-monitor, pay attention to symptoms, don't come to work if you're sick. In a couple of the other facilities, I kind of dabble in per diem. So in a couple of the other facilities that I work in, there is a very strict screening protocol. Every single staff member coming into the building is temperature screened as they walk in, and then a series of questions asked by the charge nurse, which, we're all pretty used to. Do you have any signs or symptoms? In terms of testing, I haven't been in a place that it does routine testing for the staff, but every facility that I've worked at, they've offered testing for anybody who's symptomatic, and then they've also offered testing for the antibodies. So anybody who had been positive previously, they were offered testing for antibodies, but none of it was mandatory at that moment. So right now, really just screening. And like I said, we really kind of focus on self-care at the moment. Having just celebrated Emergency Nurses Week and the Year of the Nurse, we really work on that resiliency factor and making sure that our team is taking care of themselves as well as our patients. So we advocate for, taking time for yourself, making sure that you are eating well, sleeping well, and, we also, it's unknown if it's true or not, but have heard the good things about zinc and vitamin C and vitamin D and recommend all of the above to our team. So.
Very good. Thank you. Well, how many of your staff have tested positive? Have you had any sporadic positives among your staff?
So very early on in the pandemic, in every facility that I've worked in, there were positives amongst the team. In the current wave, we have a lot more awareness and a lot more preventive measures in place, and we haven't had anybody screen positive now. But early on, March, April, we did definitely, in every facility that I work in, have positive team members. So we were very quick to jump onto those CDC guidelines and make sure that we were, keeping people out of work for the appropriate period of time and preventing any added exposure.
And that's good for the public to know that the EDs are indeed safe to go to. And with that segue for Dr. Ruzek, I have another question for you. It's been publicized that patients with symptoms of stroke and heart attack, where time-sensitive treatments exist, are delaying their presentations to the ED beyond the treatment window due to the fear of COVID-19 and coming to the ED. Have you been seeing delays in stroke patients and MIs that have actually affected their primary therapy approach?
Thank you for that question. And if there is one message that I want our audience to walk away with today is, please do not delay care. And if you need to go to the ED, you should go immediately. Unfortunately, in the first 10 weeks after the declaration of COVID-19 as a national emergency, the ED numbers declined by 23% for heart attacks, 20% for stroke, and 10% for hyperglycemic crisis. As a result, I've seen reports that pronouncements in the field where the medic gets there and unfortunately the patient no longer has a pulse have increased during the COVID pandemic versus that same very time the year prior when we didn't have a pandemic. So, the takeaway from that is if a patient wants to have indigestion or shoulder pain or neck pain or any signs or symptoms of maybe a cardiac event, if my very father was to come up to me and say, "Hey, Mike, you're a doctor. Is this a heart attack?" My response to my very father would be, "Dad, we're at home. I don't have the tools to properly answer your question. And if you have a small doubt that this could be cardiac and you thought about it enough to ask me, then we need to go to an emergency room immediately." And when you think about it, the risk of having a major cardiac event or stroke or any other acute clinical event versus the risk of contracting COVID in the emergency department, knowing all the precautions that we took, the negative pressure, everybody wearing a mask, the sanitation, it's very, very minimal. We made it that we're there every day as clinicians, and we feel completely comfortable. And if it's not good for, we would never recommend something to our patients that we wouldn't recommend to our own family members. So the takeaway message here today, if you feel that you need to be checked out because you're questioning something that could be life-threatening or even debilitating, go immediately, because the number one factor that sets you up for success is early intervention. The earlier you deal with that stroke, that heart attack, or whatever medical condition, the more likely you are to have a successful outcome. So please don't delay. And our emergency department at Capitol Health, as well as all emergency departments around the country, stand ready to take care of you.
Thank you for that message, Michael. We really appreciate it. I'm going to go back to a little bit on the mask controversy. The recommendation of wearing masks has been virtually as a national mandate, has been proposed so that we can flatten the curve, particularly with a second wave. Do you believe, and this is for you, Tracy, but anybody feel free to give a follow-up answer as well, because I'd like to know the feeling of the panel. Do you believe there should be a national mandate to wear masks indoors and outdoors when you cannot physically distance 6 feet or more until a vaccine is available and proven effective?
Thank you, Vic, for the question, because it is so necessary. So we all know, and if we don't, we know now that last Friday was the highest number of coronaviruses in the United States. We also know that there were some mandates that were lessened in certain states, including my own, for wearing masks and the necessity of them. We have worked really hard. You have all worked really hard. We've been literally on the front line, and some of us have lost friends and family members. We know that there is a deadly component to the coronavirus. We also know, proven statistically, that masks prevent and help decrease the likelihood and the level of intensity of this disease. Why wouldn't we mask? You know, a study published at the University of Washington last week showed, statistically says that approximately 130,000 lives could be saved by a mask mandate by February of 2021. So yes, I completely believe in a mask mandate, just like I believe in showing up, leaving my family to go and serve my community. I would not put any of my patients at risk in the emergency room. And I would ask that each of us who has an obligation to care for your fellow man would not put everyone else at risk as well.
Any other comments, Dr. Ruzek or Megan?
Yeah, like I said, early on in the pandemic, we really did have a lot of staff who I think we were kind of caught unawares initially. And the initial guidance from the CDC kind of was avoid the panic scenario, and people weren't masking. And that's when the people that I worked with got sick. So I think that masking is really very important. I agree, and I do think it's a challenge to be able to enforce a national mandate, but I do think it's very, very important so that we make sure that we help prevent the spread. As everybody mentioned, we're moving into flu season, and we're talking about the twindemic of flu and COVID. I think masking is probably our best effort, as well as hand washing, of course. But really, the mask with the aerosolizing effect of COVID is probably the best defense that we have for this next wave.
Very good, and thank you, Tracé, for that very, very cogent remarks on masking. I have one other question that I'd like to pose to the complete panel. ED utilization during the first 4 months of the pandemic saw a decrease in ED volumes of about 40% in the average ED, and in New York, as high as 60% decreases in volumes. What do you think is driving this decrease? Is it fear of contracting a COVID infection, particularly by high-risk individuals who are advised to quarantine, or is it job loss, economic decline, making ED visits unaffordable? What are some of the demographics of the patients not seeking care?
So I'll be happy to, share with you some of our experiences in the emergency departments I work at. And I think there's multiple components. I think as healthcare, individuals in healthcare, we did a very good job of getting out the message to our patients of stay home, stay for life. So it's great. It makes me feel good as a physician that the patients listen. So thank you to our patients for listening to us. But stay home if you're feeling well to save a life. Don't go out and, go about your daily chores without knowing that there are risks involved, and don't unnecessarily expose yourself in crowded places. So when we said stay home, we meant stay home if you're feeling well. I think our patients took it to heart and literally stayed home even when they weren't feeling well. So I am glad that we're doing this event to say it is okay to go to the hospital if you're not feeling well. It's okay to go to your doctor's office if you're not feeling well. It's okay to go ahead and proceed with that procedure that you had planned on having, whatever that procedure may be, if you're not feeling well. Because guess what? Your doctor's office is read up and well aware about COVID and is making sure none of their patients are exposed. Your emergency department, your hospitals, your outpatient and inpatient surgical centers. You know, we want to minimize risk. And when you think about it, these might be the safest places to be. You know, you ask yourself, I joke around with some of my colleagues, I'm like, you know, when patients ask me the question, should I go to the hospital? I'm not feeling well. I go, have you been to Target or Walmart or any of the grocery stores sometime this week? If you feel comfortable going there, the emergency department or the hospital is probably 10 times safer. So really putting things in perspective is important. So that's my take on it.
And yeah, I completely agree, Michael. I mean, we want you to be healthy. We want all of us, as best we can, to come through this pandemic. And so what I would ask you is to consider your symptoms. You have two things here. So Dr. Scali, in our, as we were preparing for this, did mention phone a friend. Literally take it to heart. There is nothing lost in reaching out. So call your primary doctor. We are at the emergency room 24 hours a day. Call the emergency room if you need to. You're not out there by yourselves, guys. Okay, so if there's a question, if you feel free to call. Should I come? You know, there will be certain things that we can guide you to get you to your next step. We want you to be safe and help you through this.
Very good. Thank you very much for your comments. I'd like to turn the rest of this program over to Melvin Ways, who has been categorizing some chat questions to pose to the panel. Melvin, could you share those with us?
The questions come through. Some of the points you guys have really touched on. One thing that I wanted to open up the floor to that was really interesting was, are e-cigarette vaping acute lung injuries, also known as EVALI, still presenting to the ER during COVID? The question says that they know that COVID and EVALI produce similar symptoms and present similarly on testing, and there hasn't been much discussion about EVALI since COVID has come into presence. So could you guys discuss a little bit more about other reasons to come to the ER, such as EVALI, and if those are still prevalent?
And I'm going to yield to the panel, but I did want to mention with this that when we go back to the symptoms, right? When we go to difficulty in breathing, respiratory distress, I cannot catch my air, I'm having chest tightness, I'm having overt concern, I may not know the source of your difficulty in breathing when you hit the door, be it vaping versus COVID versus multilobar pneumonia versus a developing unfortunate cancer or underlying emphysema, lung disease, COPD, asthma. But the safest place to be if you're laboring is to be with us.
Start off by saying to our audience, first of all, you shouldn't be vaping, and I hate to be the bad cop, but let's start there. So no vaping. We're not recommending vaping to our patients. So yeah, vaping does come with serious consequences, and I'm sure many of our colleagues have saw that as well. We've seen that in the emergency department on a regular basis, and we've seen really young populations, young patients that we don't normally see with respiratory symptoms come in and need to be admitted really because of the lung injury that's occurred secondary to vaping. Is that easy to diagnose in the outpatient setting? No. It takes pretty comprehensive testing, and that's something that's usually maybe even diagnosed upstairs on the floor after we've admitted the patient, because the patient might need further testing in order to determine that they have acute lung injury secondary to vaping. But it's something that shortness of breath is shortness of breath. So if you are short of breath, especially more so at rest, if you are short of breath at rest, that's telling you a lot, because, normally you shouldn't be. So if you're sitting still and you're short of breath at rest, yeah, you should be going to an emergency room. But before you do that, I want to tell you, you shouldn't be vaping. It's putting you more at risk for lung injury. And I hate to be the bad cop, but, your doctors wouldn't care for you unless they told you the truth.
Interesting. I just heard a statistic today that the vaping market has contracted from about $40 billion to $10 billion. So somebody perhaps is heeding your advice and discontinuing the habit of vaping during COVID at least, even though $10 billion is far too much to spend on vaping.
That's amazing. And you could turn that into actual health benefits instead of vaping costs. So another great question is that how often are you seeing recurrent cases of COVID coming into the ER? And are we testing for possible antibodies when we have those patients?
So I am actually not testing for antibodies in the ER. And my medicine colleagues and certainly our pulmonary docs are doing so, some outpatient. Ironically, I did work a 6 a.m. shift today, and one of my patients who is COVID positive did visit New York, no judgment at all, in January, had COVID symptoms 4 months ago, had an antibody test done that was positive, and then had a subsequent negative, and was positive today when she came in to see me at our urgent care with the rapid test being between, depending on which test and location, 60 to 84% sensitive. So that was my first double positive. So.
Yeah, and I won't speak for Dr. Ruzek, but I know that we have not seen a lot of reinfections, but we've seen people with extended positives. So they tested positive in August, they still tested positive in September, they still tested positive in October. So when we also are not doing the antibody testing in the emergency department, but recommending patients follow up with their primary care doctors. And a lot of the antibody testing that we're seeing happening around us is people who said, oh, well, you know what, I was sick in March and April, but I wasn't really sure. I didn't want to go to the ER. I stayed home, but now I want to know if I had it. But again, it's that question of, does it really provide a lot of feedback about immunity and going forward, as we are hearing in the news about the reinfection?
I will share something with our audience, and I'm going to let them in on a little secret. Us in the medical field still don't have all the answers. So, and it's very humbling. Medicine is very humbling. And COVID is something that we're still learning about. So just because you're someone who had COVID in the past or tested positive for the antibodies, my recommendation to you is that is not a sure-proof armor. There are documented cases of individuals that were COVID positive in the past that a number of months later tested COVID positive again. So those are documented cases. And this being a virus, a condition that we're still learning about, we're still, we're still experiencing, our introduction to it and the early phases to it, because we never really dealt with COVID in the past like we're dealing with it today. I think we'll be able to speak more to this in a decade, but as far as now goes, it's always the right policy to be safe. So whether you had COVID in the past or you didn't, still wash your hands, still wear your mask. You know, someone not wearing their mask and saying, oh, I already had COVID, I'm immune now, I don't think makes much sense. So it's better to err on the side of caution. It's your health. Why risk it? And why risk those around you? That's my best piece of advice that I could share.
Absolutely riveting, Dr. Ruzek. Dr. Dotson?
Yes, because as you were speaking, I wanted to add, for all of us, those of us in the world who have already been positive, there is a tendency, I believe, to be less inclined to work towards mitigation of the disease. Okay, because there is that underlying sense that, well, I've already had it. I've survived it. I'm feeling pretty good. Whew, it's over. Be mindful, my loves. It's over for you, potentially, but still, we're all in this together. So don't wear your mask less because you already had it. You know, don't be more inclined to meet at the bar or whatever the hangout may be. Just we're still working for each other. Okay?
These are awesome points.
I saw an article today that actually said that the immune response for productivity is probably about 5 months after the infection. So those people who were infected in March probably have a waning immunity at this time. So one does not know whether it's 3 months, 4 months, or 5 months of protection. So we can scare the patients a little about that, just a little.
Yeah, I think that's the fear with the second wave is the people in New Jersey, you know, they really hit that peak in March and April. And now as we're getting into that waning immunity, we're hitting that second wave. And I think that people are feeling good, like you said, Dr. Dotson, that, you know, they had it, they got through it, they're not having a lot of effects afterwards. And I think that they really need to keep that vigilance and making sure that they stay aware of their symptoms and staying safe.
Great point. And we probably have time for about 1 or 2 more questions. We have a lot of great participation from our attendees, so I really want to thank everybody for that. The next question would be, do you think patients are going to the ED more for less than severe reasons because of their doctor's office being closed or only televisits? So again, do you think that patients might be utilizing the ED as opposed to their family physician's office because it's closed or only taking televisits?
Great question, Melvin. And the answer to that is, I'll tell you what we're seeing on the ground. What we're seeing is still significantly less patients compared to the number of patients that we were seeing this time last year or the year prior, pre-COVID. So most emergency departments, their volumes have not fully recovered to their pre-COVID volumes. They're slowly starting to rebound because individuals and patients are slowly getting the message that it's okay to go to the emergency department if you need help. That's what we're there for. But I wouldn't say it fully recovered. So the emergency departments have the capacity to take on even more patients than what they're seeing now. Again, we do distancing in the emergency department. We separate patients who are symptomatic or high risk from patients that aren't. We've taken multiple interventions in the emergency department. And the patients that we are seeing are made more sick and more acute than your normal patients. So we're seeing patients later on in their disease progression. And, you know, that leads to more admissions, more interventions, you know, and the list keeps going on because, you know, if I was to see that very patient with the cellulitis, say, for example, I could probably treat them with oral antibiotics and send them home. But if I'm seeing the patient later on in the disease progression, they might require IV antibiotics, admission, and in the worst cases, they may be septic, where it's a systemic disease and it's life-threatening, where the infection gets in the bloodstream, and it's not a road that's beneficial to the patient. So why wait for the disease to really take its course and to progress? Early intervention is the best intervention, but unfortunately, we're seeing less patients right now in the emergency department, but those less patients are sicker than the usual patients that we see.
Awesome. That's really a great point. And I think we probably have time for one last question. So how have you had patients react when you in fact tell them they are COVID positive? Because there could be a lot of concern, we could call it panic for lack of a better word, about, having COVID and what it could entail. So in fact, have you had patients react in a bad way when you've given them a diagnosis of COVID?
I'm trying to, I hope I'm not too loud, guys. Can you hear me well?
Yes.
So I think we get all flavors, but we get that in the ER anyway. Right? So I think it makes us uniquely prepared, perhaps compared to some specialties, because we never know what's coming in. We never know the conversation we're going to have. And so it arms us with the ability to say, this is what we have. This is what you're dealing with. This is what you can expect. So we educate. And people feel, when you empower them to know what they're looking at and what they're dealing with, they leave, armed with the ability to say what their next step is. So, yes, I've had some bad reactions, some tears. I will cry with patients too. You guys probably figured that out. But in the midst of consoling, the greatest gift you can give someone, and that I hope we're giving to everyone here tonight, as well as the community, if you arm them with the knowledge of what to expect. I send patients home all the time, including the young lady I spoke about earlier today. We do have a home monitoring system here with Advent Health, where we actually give them a pulse oximeter and we give them a thermometer, and our infection control system calls and checks on them daily to gauge their symptomatology. That's for some specific cohorts, not for every. But obviously, if we're watching a pulse ox, if we're watching a level, and people are more willing to go home. They know that they can trust that they're going to be checked on, and it gives them hope, and it lets them know we've got you, and that I think that really matters.
That's about as good as it gets. That's a great answer to that, because I know I'd personally be freaking out if I came through with COVID and you told me I might need to stay in the hospital for a few nights. So thank you for that, Dr. Dotson. And I think that concludes our Q&A portion. I really thank all the attendees for their questions and the panelists for their humble answers, and really appreciate everybody coming out tonight. I'll turn it over to Dean Machichi to help close this out.
Thank you, Melvin, and thank you everyone who attended this evening's webinar. We really do hope you found it beneficial to learn about precautions that the emergency rooms have taken during the pandemic, and give you some important information to help you and your loved ones make decisions about when to visit the ER, especially during this time of COVID. I will tell you this session was recorded and will be available on our RowanSOM Alumni page by next week. I want to give a very special thank you to Dr. Scali, our SOM alumni, Dr. Dotson, Dr. Ruzek, Nurse Martinson, for your time, for sharing your expertise on this important topic. Thank you also to our second-year student leader, Melvin Ways, for your participation. Great job. Finally, many thanks to our webinar advisory committee, our alumni webinar advisory committee, that's led by Dr. Ashkan Al-Shanawi. as well as our SOM team members, Ms. Gail Foreman, Ms. Nora Casper, and Ms. Brittany Quintana for many contributions. You know, this series has been a special collaboration between our alumni and the medical school, and we are appreciative of input and support from so many to bring this series to you. I want to close by telling you to plan to be at our next alumni webinar, which is Tuesday, November 17th. Note that the time will be 6:30. The start time will be 6:30, not 6 p.m. The November program topic is Navigating the Holidays During a Pandemic, a guide for your entire family. This will feature our own Dr. Rachel Schmutz, Vice Chair for Education in our Department of Psychiatry, Dr. John Bertinoli, Professor in our New Jersey Institute for Successful Aging, and others. In closing, I want to remind our attendees to keep up to date with happenings, news, and programs for Rowan University School of Osteopathic Medicine. You can like our Facebook page, you could follow our Instagram, and you can find both at the RowanSOM Students and Alumni. So if you search that, follow and like, and you'll keep up to date on a lot of stuff going on with our students and alumni. So in closing, thank you. Thank you again for everybody's time, for supporting this webinar series, and I wish everyone a very good night.